One. We are live.
Okay, good evening, everybody. Welcome to today's webinar brought to you from the Orthopaedic Research and Education Foundation, being broadcast through OrthoTV. Today, we have the pleasure of having Professor Hitesh Shah from Manipal with us, and he's going to talk to us about skeletal dysplasias, how to approach it and manage them. And he's basically going to touch on important points which orthopedic surgeons should know when they are faced with the case of a skeletal dysplasia. Obviously, it's a huge topic which is impossible to cover in detail within the 45 minutes. But I'm sure Hitesh is the best person to try and make it as simple as possible for everyone to understand. So over to you, Hitesh.
Thank you. Good evening. Thanks for the introduction. And whether my screen is visible?
Yes, it is. Just need to make it full.
Yeah, just a minute.
No, it's disappeared now.
No, I changed it.
Okay. Yeah, now it's full. Okay, great.
Yeah, sorry. Yeah, so the good evening, everybody. Actually, I'm going to talk on the skeletal dysplasia. We are going to talk on the management of the skeletal dysplasia. Before that, we need to say about approach to skeletal dysplasia. The skeletal dysplasia is a vast topic. It is very difficult to combine each and everything for the management of the skeletal dysplasia. But what I am going to do is that I'm going to cover such topic in the next 40 minutes. What is actually skeletal dysplasia, how it is different than the dysostosis. When the child comes with all of us, how to approach the child with the skeletal dysplasia, what are the relevant clinical examination points, radiological points, and molecular diagnosis. Basically, we are orthopedic community, so we need to know what are the orthopedic issues with the child with the skeletal dysplasia, when to do the surgery, when not to do the surgery. It is also very relevant. The types of surgeries, I'm going to discuss a few cases and show how we deal with the case with the skeletal dysplasia. So the skeletal dysplasia is a heterogeneous group of the bone and cartilage disorder, and that result in the abnormality of the growth. Basically, when we talk about the dysplasia, it is the abnormal organization of the cell into the tissue and usually affect the entire skeletal system. And that particular tissue, when it is present, whether it is bone is affected, it will involve the entire bone. Whether it's a metaphysis involvement, entire metaphysis will be affected. Or it may be the osteosclerotic type of or osteopenic type of condition. How it is different than the dysostosis? Whenever the malformation of the bone happens, whether it's singly or is in combination, it will be called as the dysostosis. It would be different than the skeletal dysplasia. So if you see like a radial club hand or the limb deficiency, or it is involvement of the one limb or one part of the bone or the segment of the bone, it would be dysostosis. If you see about that involvement of the entire skeleton, whether it is the metaphysis, the physis, or epiphysis, or the diaphysis, or involving all the parts with the spine and the bone, it would be a dysplasia. This is an example of that metaphyseal dysplasia. So why we are discussing? What is the reason that the orthopedic surgeon should know, orthopedic resident, consultant, and everybody should know that we need to know about the diagnosis, and that's why we are very much interested, because diagnosis, we can make it, then we can predict about the prognosis, and we can think about what is going to happen with the child with skeletal dysplasia. Once we get the diagnosis, we need to find out what are the orthopedic abnormality or the skeletal abnormality, and that will require the intervention. Defining indication for the surgery and performing what type of the surgery is needed for the patients. So why it is required to know the diagnosis? Because most of the people will say it is not our job to send it to the geneticians to find out the diagnosis. But if we know about the diagnosis, we know what are the probable complications. We cannot predict every complication. You can see what would be the height or the stature of the patients, whether it is less than 3 standard deviation or whether less than 5 standard deviation. And it will be also very important to understand whether the next subsequent generation will be affected or not. If the family knows about the diagnosis, it will be involved in the psychological support of the patients and peer groups. So how to do about the diagnosis? What are the important clinical, the radiological and molecular examination? Because the no diagnosis would be full form unless we need to have the combination of clinical genetics and molecular diagnosis, radiological diagnosis. Previously, the 100 years back, whenever the skeletal dysplasia was there, the clinician came in pictures and they said whether it is a proportionate short stature or disproportionate short stature. Then came with the radiologist and they said depends on the metaphysis or the epiphysis or diaphysis. You can say it is the dysplasia, skeletal dysplasia. Then came at the molecular level, whether what type of gene is involved. So we need to have a combination of all clinical, radiological, and molecular diagnosis. We'll go one by one. I'm not going to discuss the molecular level, but what is relevant in the short stature. The very important, the issue with the type of the skeletal dysplasia, the commonest thing is that disproportionate short stature. There are thousands of the cause for the proportionate short stature, like the physiological, constitutional, the endocrinal. But whenever child present with the disproportionate short stature, that most common and the common cause is skeletal dysplasia. What is the proportionate? Upper segment, lower segment ratio. So whenever the upper segment, lower segment ratio is altered, normally up to 10 years, the upper segment is longer. Beyond the 10 years, at 10 years, it will be equal. And after 10 years, it will be altered. But whenever the upper segment, lower segment ratio is altered, it will be called as the disproportionate short stature. So if you see about the child which is presented like this, we can say it is presented like a short trunk. Or if the child presented like that, it will be present with the short limb. Then both would be present in case of the skeletal dysplasia. In broad, we can say it may be the short trunk or a short limb. It may be possible to have the shortening of the trunk as well as the limb, and that will go in the proportionate short stature. I never said that proportionate short stature is not a skeletal dysplasia, but whenever it happened, the disproportionate short stature, it is none other than the skeletal dysplasia. If there is a proportionate short stature, we need to rule out about endocrine problem, the metabolic problem, and all other problems. But whenever there is a disproportionate short stature, it must be the skeletal dysplasia. What are the things we must understand for the clinical evaluation? When the child is present at birth, lethal or a perinatal, neonatal or a postnatal, because the most of the dysplasia may not be evident. If it is a congenita, it will be present at birth, but it is a tarda, it may present in later in age. The commonest dysplasia is achondroplasia, but again, it would not be detected in early pregnancy up to 24 weeks of pregnancy. It would be detected after 28 weeks of the pregnancy. But then it will come about the stature, whether it is the less than 3 percentile or whether it's a less than 5 percentile, whether it's a proportionate or not proportionate. As I said, it is always do about the clinical examination. It is very important to understand the height of the child, and that is the important aspect to diagnose about the dysplasia. Then we need to say about the height, the sitting height, upper segment, lower segment ratio, and arm span. Like the arm span ratio would be altered in case of the Marfan syndrome. The most of the cases, the commonest dysplasia, rhizomelic dysplasia, is with short trunk, it will be the achondroplasia. So whenever we'll see about a child with the short stature, we can say, is it a proportionate short stature or disproportionate stature? Whether upper segment, lower segment ratio is altered or not altered, whether the arm span is normal or abnormal. That is very important to understand which type of dysplasia is there. Then we need to discuss and see about what type of the limb involvement. Let us say first is stature, proportionate and not proportionate. Then say that what type of the limb is involved. It's very common that it is called as a rhizo. Rhizo means a proximal fragment or the proximal segment. The thigh and the arm would be short. That is called as the rhizomelic dysplasia. Is it a rhizomelic or is it a mesomelic? Mesomelic means middle segment. whether this is a forearm or the and leg would be involved. That is called as the mesomalea. Third would be the acromalea, whether it is the upper limb is the hand or the foot part. The distal part of the limb is involved. So the clinically, is it comes in the rhizomelic, mesomelic, or acromelic. Many times it will be combination of all, but if it is there, then it is called as the micromalea. It is that entire limb is short. So that is important to know about the clinical evaluation. Then it comes about the dysmorphic features. If the child has got the present with the facial dysmorphism, cleft palate, cleft lip, whether it's having myopia or a cloudy cornea, because many of the dysplasia would be common, like a Marfanoid features will be common with the myopia and the lens complication. It was very common to have neurofibromatosis with the optic problems. So you need to check about the eyes and see about, or it will be associated with the systemic disorder like hepatosplenomegaly, when there is a lysosomal storage disorder or there is a Piles disease would be associated with hepatosplenomegaly, whether it is associated with the cystic kidney or not. It is very important to see about the general examination to identify whether it is associated with the other systemic problems or not. Then it is not only our duty to send it to the pediatrician sensei. We need to find out whether it is one family is skipped or the every family is involved, to find out whether it is the autosomal dominant condition or a recessive condition, or is it an X-linked dominant condition or a recessive condition, whether it is run in a family. Many of times you may not find any positive family history and sporadic case would be present. It is a very common scenario as well in India also. But if it is possible, we need to find out whether it is parents and grandparents, particularly about paternal and maternal grandparents, we need to ask to find out what type of disorder would be there. Because these are the important, the history and clinical findings it's needed to diagnose about the skeletal dysplasia. Then we'll come for the radiological examination. This is very important. The slides is very important because any suspected case of the skeletal dysplasia will require about the skeletal survey. The skeletal survey includes the X-rays of the skull, X-rays of the entire spine, including cervical spine, AP and lateral, the chest X-ray, pelvis X-ray, upper limb X-ray, including the hand and elbow, and a lower limb X-ray, particularly involving both knee and pelvis both in particular cases. Basically, when you want to know about the age of the patient, you can order about the wrist and hand X-ray to find out whether the carpal age or bone age is normal or not. By and large, skeletal dysplasia can be detected by only doing about skeletal survey. So it is very important to do about the entire skeletal system examination. By that we can detect whether it is apicipicial dysplasia, metaphyseal dysplasia, whether it's a diaphyseal dysplasia, whether it is a spondyle, the spine is involved. It's a spondyloapicipicial, spondylometaphyseal, depends on the varieties of the dysplasia. We can say about what are the involvement. If you order about the X-ray, what to look for? What we need to find out, what anatomical location, whether it is very, very simple. And I insist we can read about, this is a pediatric radiologist. Both are a pediatric radiologists are very well known from the UK, the Ophelia and Hall. We can find out this is the very simple classification. They have got it, and they tell what to look at for the detecting a skeletal dysplasia. How to approach a child with a skeletal dysplasia from the radiological point of view. We need to find out what anatomical location is there, what bone is involved, what are the complications when the D is dead or alive. So we'll come to that point, whether it is anatomical location depends on the involvement of the particular bone, that is the diagnosis, whether it is the costello or the clino, because it's a clavicle is involved. Spine, it is called as spondylo, whether the pelvis is the ilio, ischio, or a pubis, whether it's a cranio, because there is a combination of the dysplasia, whether craniometaphyseal, craniodiaphyseal, the facial nephropathy, cranial dysostosis, whether the spondylometaphyseal, whether the ischioidial, depends on the involvement of the location of the particularly anatomical location, abnormality in the spine, skull, face, mandible, or a rib or pelvis. Then coming to the long bone, whether it is metaphysis, epiphysis, or diaphysis, particularly what you need to check, whether it's abnormal bone quantity, quality, whether it's a sclerosis or osteopenic. Then about the shortening, as I discussed in clinical examination, whether the femur or humerus is short, it's rhizomelic, whether the tibia or the radius line is short in case of mesomelic, or whether it's a hand and feet is small, it's a acromelic. See about the bone, whether it's the structure of the bone is normal, size and shape is normal, or the soft tissue shadow is abnormal or normal. Complication, whether the joint is normal or it dislocated or subluxated. And very important to know about the limb length discrepancy, like the Ollier's dysplasia. The Ollier's disease will always involve the one side of the body, or the malariostenosis will always have the only one side of the body, and that will be presented like a limb length discrepancy. Where it is a fracture, very, very common to have the osteopenic and osteosclerotic condition, like osteopenic condition, osteogenesis imperfecta, osteosclerotic condition like the osteopetrosis will be present with the fracture. The joint dislocation type of the joint dislocation, muscular contracture or joint dislocation would be common in case of the complication. So we need to find out the ossification, whether it is affecting epiphysis, whether it is a physis, metaphysis, diaphysis or not. What is important to find out whether it's epiphyseal, whether it is normal or abnormal size and shape. You can base it whether it is a hypoplastic or a irregular. Similarly, whether it is a metaphysis, we can see in a second part, it's irregularity or a widened. Whereas many times it would be widened. Metaphysis, very commonly it will confuse with the rickets. One important point I like to highlight, in case of the rickets, there would be metaphyseal osteopenia because of the unmineralized osteoid. In case of the skeletal dysplasia, it would be sclerotic. So very commonly ask a question, which type of rickets will be having differential diagnosis, like in case of skeletal dysplasia, the Smith type of the metaphyseal dysplasia would be presenting exactly like rickets, would be widened metaphysis with irregular metaphysis, but in case of the Smith dysplasia, it would be sclerosing, while in case of the active rickets and nutritional rickets, it would not be sclerosis. Though the hypophosphatic rickets would be exactly looking like a Smith, but we need to differentiate with the metabolic marker. Then for the spine, whenever the height of the spine or the vertebra will be decreased, it will be platispondyle, whether it is normal or irregular in shape. So in combination of the normal spine and the normal limb, whether it is normal or not, or if it is involving the spine and epiphysis is spondyloepiphyseal dysplasia, if combination of the spine and metaphysis is spondylometaphyseal dysplasia, or combination of epiphysis and metaphyseal changes with the platispondyle, we can say the spondyloepimetaphyseal dysplasia. These are the very important slide to understand what type of dysplasia we are dealing with. These are the few examples. The child has got the avascular necrosis. We can say the density is changed with the pseudo-rheumatoid. This is an example of the pseudo-rheumatoid arthritis, where we can see the abnormality in case of the metaphysis, where the metaphysis is sclerotic and it's separated. And very important, we can see there is a sclerosis in the fibula physis. Very important because abnormal changes are there. Many times people will get confused with the Blount's disease, but this is not a Blount's disease. This is a very typical case of the diaphysis is abnormal, where you can say this is a diaphyseal dysplasia. It's a diaphysis is broadened and widened compared to the opposite side, where it's the diaphysis is both. So another example of the diaphyseal dysplasia, but it may be keeping in mind the rickets may present also with the bowing of the long bone, and that would be another. This is the example. There is a spine is the height of the spine is reduced, where we can say this is case of the platispondyle. That is very, very common with associated with the metaphyseal and epiphyseal changes. The few points on the bone density, either the bone density would be normal, or whether it is the less or it will be more. So if you see, or it will be focal, it's only involving a part of the one bone or particular one side, or whether it's a very, very sclerotic, or like the Paget's disease or the osteopetrosis or regurgitative appearance in renal osteodystrophy. So we can understand that whether the bone density is abnormal or normal. Very common case where the bone density is reduced in case of the osteogenesis imperfecta, while the osteoporosis would be there in osteogenesis, while the osteosclerosis is there in osteopetrosis. Many other conditions like fibrodysplasia are there, but I am considering very, very common cases of skeletal dysplasia. What are the sometimes unique features? We need to find it that the carpal bone is disorganized. This is a case of the carpal osteolysis where the femoral head gets disorganized. It may be happening with epiphyseal dysplasia with a dislocation where it's having both sides is asymmetrical in way. Last but not least, for the diagnosis, I will suggest whenever you are in doubt, we can go ahead and refer such paper like nosology and classification. Genetician has come with the classification every 5 years. They came in 2006, then 2010, 15, 19, and new classification in pipeline that comes in American Journal of Medical Genetics, and they combine all the group of disorder like osteosclerotic type of condition, metaphyseal disorder, and they combine according to gene, like FLNP gene or CHS3 gene, depends on what gene, whether the COL1 or COL2 or a COL1A1, whether it depends on that, they group together and dysplasia. So whenever we are in a doubt, we can refer such paper and find out what type of dysplasia for the diagnosis. Coming to the points on the orthopedic points of view, what are the problems with the orthopedic problems in case of the child with skeletal dysplasia? The commonest problem is the limb deformity. The limb deformity is the commonest, the problem for that the child would be brought to the consultant, the orthopedic resident, either it would be Januvarum or Januvalgum. We must be differentiating from the case with the identical or the bilateral symmetrical, and there is a under the age. If child is less than 2 years, there is a possibilities of the physiological Januvarum. If child is between the 3 to 7 years, it is with the Januvalgum, it will be bilateral symmetrical, it's having the physiological. How could differentiate between the physiological and pathological Januvarum? Whenever we'll find the asymmetrical Januvalgum or a Januvarum, it is always pathological. Whenever we'll see the Januvarum beyond 2.5, 3 years of age, this is always pathological. Whenever we find a Januvalgum beyond the physiological age, less than 3 years and more than 7.5, 8 years, then it is always pathology. Same, whenever it is not getting resolved, it's getting it progressive, it's always in a pathology. So in case of the skeletal dysplasia, it will be pathological deformity of knee joint. It will be associated with the asymmetrical, the short or disproportionate short stature, and associated with facial dysmorphism, we can say it is a case of the skeletal dysplasia. Another problem is that limb deformity and the spine deformity. You may have the kyphosis or the scoliosis or a severe kyphoscoliosis. Another issue we can have in orthopedic having a recurrent fracture. As I said, it may be associated with the metabolic problem. It may be associated with the osteopenic problem like osteogenesis imperfecta, or it may be present with the osteosclerotic problem like osteopetrosis, or maybe having renal problem like renal osteodystrophy in the like 3. So these 3 are the all may present like a recurrent fracture, but all the management would be different where because it is required to increase the bone density when there is osteogenesis imperfecta. When it is there in case of the renal problem, we need to address the renal problem first before going for the fixation or definitive treatment. The third issue is the unstable joints. The unstable joints may be the axial or appendicular. The axial problem will be the spine, and the appendicular problem is that it will be the hip joint, knee joint, foot joints. It's very common to have the unstable joints. It is called with the joint laxity or a joint dislocation. That will be very, very common with that. Or maybe having unstable spine. The very, very important aspect of unstable spine, I'm going to discuss one case on that, but whenever there is a child with skeletal dysplasia, always examine the spine, and particular for the cervical spine. If the cervical spine is unstable, we are taking the child for the deformity correction we will make about unstable spine into the paraplegic or a quadriplegic if the unstable spine is not been stabilized first. So we need to take a proper precaution to find out whether it's unstable spine is there or not. And that is the reason it is always important to check about the cervical spine instability in every single case of the skeletal dysplasia. So this is also very important: deformity of the spine, deformity of the limb, unstable or the stability of the joint, and stability of the spine. It may be also cervical spine or a lumbar spine or thoracolumbar spine. We can see in the last slide, the right side, it would be thoracolumbar spine. Another presenting feature or the symptoms of the patient would be the pain. It may be pain of the arthritis pain, or it may be the mechanical pain. But very common we can have its affection of the mechanical axis is altered, or the disproportionate of bone and cartilage. It may present with the pain. The arthritis will be irreversible and quite progressive. So very common we can have the hip joint arthritis in such conditions. So it may be also having a pseudo-rheumatoid dysplasia or spondyloartificial dysplasia. How to address? We know that these are the issues with the skeletal dysplasia. How to address such principles? So we need to correct about the deformity of the long bone, restoring the normal alignment as far as possible, improving the stability of the unstable joint, prevent the recurrent fractures and prevent the recurrent deformity, minimize the propensity of the fracture. If it is like osteoporotic condition or the recurrent fracture, always add the intramedullary fixation in order to prevent the recurrent fracture and deformity due to the malunion or the microfracture. Correct the limb length discrepancy. Whenever there is a limb length discrepancy is there, we need to address about the either doing about epiphysiodesis or do about lengthening procedure. The last but not least, the goal would be the relieve the pain. If it is arthritis, very, very difficult to address the arthritis in a child, but we need to relieve a pain in case of the child. So before going for indication and showing some case, I will always highlight when should we avoid the surgery. When should we avoid the surgery is also very, very relevant in that. If this is like a osteopetrosis and that's carbonic anhydrate deficiency with severe coxa with abnormality and bone, when the child is having no functional limitation, try to avoid because you may break the lot of a drill bit on that. Another point where we can say it's a very typical the skeletal dysplasia, the fibrodysplasia ossificans progressiva, it can be detected with the abnormal bone all over the body. And very, very common to have a first metatarsal and metatarpal is short. So whenever we see about the first, the thumb or the great toe is short with abnormal bone everywhere like exostosis, think about the fibro-ossification dysplasia. And particular this slide, if you can make out, the child was given with the IV line, and IV line also has thrown a new bone. And particularly any intervention on such cases, that can lead to the new bone formation. So this is the cases you should not treat anything with the operative intervention. Never ever treat the child. This is another example. These are all three are different child. This child was treated with the corticoplasty, and the entire corticep has been fibrotic, become the bony. The myositis ossification, like the entire ossification happen on the corticeps. So try to avoid such condition. Can be treated with other way on the non-operative treatment. Few case example, the deformity correction, the child was having the severe tibia vara, and there is a case of the spondyloepiphyseal dysplasia. And if you see the X-ray, there is a cora at two different levels. So whenever that we see about the child with the deformity, we need to apply about the principle: where is the deformity, where is the site of deformity, where is the maximum angulation in sagittal plane, coronal plane, and transverse plane, and find out where we have to do about the osteotomy. So these are the different plane where it is required to do about the correction. And the child was treated with a different approach. We can't treat it all together, and did with first with the distal part, then we did about the proximal part, and ultimately the limb has become the equal and the straight. So if you see about the alignment of the knee joint and ankle joint is almost horizontal, and that is needed for the mechanical malalignment correction. it can be treated with the intramedullary road or it can be treated with external fixator if bone quality is normal. If bone quality is osteoporotic or osteopenic, always use about the intramedullary devices. Another case, this is a typical example of the Alice 1 pivotal where there is lateral part of the tibia is always defect, and because of the genu valgum, the patella gets subluxated. These are the very classical case of the Alice 1 pivotal. So what are the issues here where there is a distal, the proximal tibial defect with the patella subluxation with the genu valgum, and the lateral part is growing differently than the medial part. So we need to correct with the deformity correction with the prevention of the recurrence. So we did about the osteotomy, correct about the mechanical axis, and did before the growth modulation came with the plate epiphysiodesis, we did with the staple, and to put about the correction, and the child's got very almost straight. We can say that patella also get it reduced, and in this at the follow-up period, we can see there is a getting about regeneration of lateral side of the condyle, and it's quite reasonable to the skeletal maturity. Third case, where it's a child presented with a severe type mesomallic dysplasia, where the tibia and fibula were short, presented with severe ankle valgus, and we see about the deformity planning, the wedge shape about the distal tibial epiphysis with the proximal migration of the fibula station, with very differential growth about the tibia and fibula, and because of that, along with the growth abnormality of this tibia, it went into genu severe the ankle valgus. The child was treated with the first about the osteotomy, and we see about the wedge shape epiphysis remain the same. So child was treated with the growth modulation, and it is quite reasonable, and the follow-up the child has maintained. He is also skeletally mature. It's quite straight compared to the previous one. This is the last X-ray. That one of the bone on the fibula is not united, but she is symptomatic on that. The fourth case, the child is presented with the hereditary multiple exostosis with one side valgum and one side varum. When the child has got the varum and varum windsweep deformity, with the boy has got a lot of growth left on side. It's the simplest and easiest is that growth modulation. The valgum is treated with the hemiepiphysiodesis on one side, and the varum was treated with the lateral hemiepiphysiodesis on the lateral side. And in follow-up, we got a good correction after 12 months. The child has got perfectly mechanical axis and implant was removed. What should we do when the child present near maturity or the sick physis like hypophosphatemia rickets, which child was treated with the bilateral femur and tibia in a stage-wise, one side the femur, then opposite side femur, and corrected with the proximal tibial osteotomy, and mechanical axis got corrected at the follow-up in the hypophosphatemia rickets. Few points on the osteopenic condition with the recurrent fractures. Like common is that the osteogenesis imperfecta. We need to do about the growing rod ideally, because non-elongated rod will not grow along with the child will grow. Either use about telescopic rod or the double rush rod. It depends on the availability surgeons compared. We can use about the implants on that. This is an example. The child is treated with the double rush rodding, and as we can see, the child is growing up to 2 years, 3 years, and 8 years. Almost the rush rod is protecting entire length of the femur, and it did not require revision. Generally, revision is required around, we see about 5 to 6 years. And if we compare about the rush rod and the double rush rod and telescopic, the survival rate is similar. Few examples with the tibial bowing. The severe tibial bowing, it's been treated with the osteotomy, and the child is quite well. Similar example, when there is a bowing of the humerus and radius ulna, the child was treated with osteotomy and multiple rush rodding and squatted better. So the first deformity of the long bone, then there is a recurrent fractures. It has been treated with the intramedullary rod. The third issue is the joint alignment. So whenever the joint is abnormal, either it is dislocation, subluxation, or a coxa valga or a coxa vara, it has to be addressed. Like this is a spondylometaphyseal dysplasia with severe unstable offset, because we can see there is a, let's say the physis almost get slipped. It's been treated with the stage surgery with valgus corrections. Varus is corrected with the valgus osteotomy with the lateral translation. It's remained the maintained. It's very common to have the recurrence of the coxa. This is another child is having syndromic child, dysmorphic patient with the mental retardation, with having the multiple sclerosis with the almost bilateral hip is subluxated with the valgus slip capital epiphysis. And then what we see about the option we need to put about the epiphysiodesis or single screw from medial to lateral side, and the both side was getting it subluxated. So it has been treated with its bilateral varus osteotomy and got good inclination on the both side. How to correct about the joint stiffness? This is an example. The child, 5-year-old child, present with the on the triceps calcium. This child is presented like myositis ossificans, but myositis ossificans is very common on front side, not on back side. So if you see about the skeletal survey, it was entirely essentially normal. But if you see about the phosphorus, which is very, very high, so child was treated with the phosphorus binding agent, and later it was excised with the mass, that is tumorous calcinosis was excised, and 1 year follow-up child has got the good non-stiff or the functional range of motion. How to improve the stability of the joints? This is a child with the Still syndrome with the bilateral dislocation hip. The child has been treated with the sequential open reduction, femoral shortening, and acetabuloplasty, and 5 years later, it's reasonably, it is not normal. I am not saying it's normal, but it's a reasonable hip after the 5 years following the surgery, and the child is ambulant with no other problem. If it is don't treat the patients like this is the patient, it's not a child, it's 23 years young man presented with pseudoachondroplasia with the height is only 100 centimeters. If you see the patient, you can see this must be the child of the 6-year-old, but it is not 6 years. The entire tibial length is the 12 centimeters, and this is the X-ray. So it's unstable knee, and this patient was presented to the orthoplasty surgeon for the severe knee pain, and because of the knee pain, he stopped walking, and it was referred to him for the arthroplasty. But the 12 centimeter we can't do about the arthroplasty. It's such a smallest implant would not be possible. So if we see about the X-ray, it's involving the entire skeleton. It's a pseudoachondroplasia, and we plan that. We do about the sequential surgery, and the final follow-up, the recurrent gets corrected and is ambulant without any problem. These are the two brothers presented with a severe joint laxity, both sides, the hip dislocation, knee dislocation, severe laxity, and because of that, they both were non-ambulant. These are the sequential, their own X-ray, which been tried with hip dislocation. And these are the X-ray with the spine, which is having the severe involvement of the platyspondyli, the spondyloepimetaphyseal dysplasia with the joint laxity, the leptodactyly, which we reported. But the child has got the severe laxity of the knee joint, and it's been operated with the corrective distal femur osteotomy, and the child is ambulant and able to ride the bike. But this child presented after a few years with the fracture of the femur, because they are ambulant and able to ride the bike. Another issue is the correction of the limb length discrepancy. How to correct about limb length discrepancy? Very common to have coleus. It's involved the single bone and single side. It can be corrected with sequential limb lengthening and the opposite epiphysiodesis, or it may be having one bone, like the hereditary exostosis, multiple exostosis. We can do about lengthening of the ulnar bone whenever it is short. What should you do for the unstable spine? This is, as I was talking in beginning, the child was having the COL2A1 deficiency with the spondylomani type of the dysplasia, spondylometaphyseal dysplasia. The child underwent multiple surgery for correction of deformity. Child was ambulant, but after a few years, the child couldn't able to walk. An examination revealed the quadriparesis. So when we took about the MRI, we can see about there is a severe compression at the atlantoaxial joints, and the child showed about the hyperplastic, the tense, and it was showing the unstable. So the child was treated with the atlantoaxial fusion, and this is 1 year following surgery, and child regain about the neurological deficit which we lost it in that. But prevention is always better than cure for such patients. Last but not least is the arthritis. Whenever there is a pain, and this is not a mechanical pain, rest pain with range of motion is restricted, more than 50% restriction, very, very common in case of the Handigodo and pseudo-rheumatoid dysplasia. So it is very, very difficult to get such conditions. This is the 13-year-old girl presented with disproportionate dwarfism with dislocated hip and is having severe flexion deformity, and child stops walking because of the severe hip joint problem. And if you see about that, the epiphyseal changes was quite marked, and we are fortunate to have find out the diagnosis. It's a CHST3 deficiency, and the child was treated with external arthroplasty. And if you see about that, it's deformed and articular surface is eroded all over the place, and child was able to regain the hip joints. So its incapability of the pain started walking. The child was not having pain and able to lie down supine, and backache got also relieved. Another aspect is bilateral symmetrical involvement of the hip arthritis treated with the excisional arthroplasty and the pelvic support osteotomy, but future THR would be the problematic. It is possible, but and another peculiar problem near the Karnataka, near our place, is Handigodo, where there's bilateral involvement of the hip, either the subluxating type or the protrusive type. It will require the total hip replacement, but it is near at the adult, adolescent, or near adulthood. Otherwise, the pelvic support osteotomy would be one option. So I will conclude the orthopedic management of skeletal dysplasia depend on the deformity of limb, spine, osteoporotic bone, osteopenic or atherosclerotic bone, instability of the spine and the joint. The growth modulation is quite simple, safe, and effective for the deformity correction in children whenever it is growing age. Deformity correction in osteopenic bone, we can think about always intramedullary nailing. Joint dislocation can be dealt with soft tissue release, and the cervical spine instability should be always screened before doing about skeletal dysplasia surgery. We need to check the serial follow-up time intervention to prevent the irreversible complication. Thank you. Any question would be most welcome.
Thank you so much, sir. Sir, we have few questions in the chat box, sir. One from Dr. Narayan. You want to know the second question I have first asked, that why left hand X-ray is done for age estimation during skeletal survey?
Yeah, because the clinical examination is first. Whenever there is asymmetry, you will take about the both. But when there is a symmetry, you will take a one. So the all year cannot be missed, because you do the clinical examination first before ordering the X-ray. And second, the bone age always the one side, whether it's the left side or right side, it is the same. So it's symmetrical, always take one side. Otherwise.
Yeah, that is in the second question he has asked why we take only one upper limb and lower limb X-ray during a skeletal survey. Why not both upper and lower limb? Because of Olier's dysplasia is unilateral condition cannot be missed in unilateral X-ray. For the same thing he has asked in the question, sir.
I think we've lost Hitesh.
Yeah, maybe, sir. Yes, sir. Yeah. I think. Okay, sir.
Something's wrong.
Yes, sir. So
I think the answer is the same as the first question, yeah? The insymmetrical one side is enough. But if it's asymmetrical, then you need to take both sides. So it's the same.
So, and that, as sir has explained, that for the dwarfism can be considered as skeletal dysplasia, not stature. All the dwarf or only disproportionate, because this is little confusing. Yeah, sir is here now.
Sorry,
Yes.
Can you hear me?
Yeah.
Yes, sir.
I lost the connection for one.
Yeah.
Can you repeat that?
Yeah, please. Yes, sir. Why we take only one upper limb and lower limb X-ray during a skeletal survey? Why not both upper and lower limb? Olier's dysplasia is unilateral condition, cannot be missed in unilateral X-ray.
That's why I already said that, because Olier's will do about the clinical examination, and Olier's is there. Whenever we'll take about the hand X-ray, we'll come to know about enchondroma. So it's a multiple enchondromatosis. Similarly, when you do a clinical examination, one upper limb or one lower limb would be short. So always take about one side X-ray is enough because it's bilateral symmetrical. One side X-ray is enough.
So, one thing which I want to ask, because as much we understood from that one that all the dwarf can be called as a skeletal dysplastic. Maybe means disproportionate is always a skeletal dysplasia, sir.
Yes.
But proportionate maybe that.
Yes, proportionate maybe, but if it is a proportionate short stature, we need to investigate whether it is the endocrine problem, whether it's proportionate, both parents are short or not. Whether it is more than 5th centile, then it's okay. But if it's less than 1 percentile, possibility of skeletal dysplasia is more. But we need to rule out all causes like endocrine, metabolic, proportionate, and that. But if it is disproportionate, it's always skeletal dysplasia. Doesn't mean proportionate is not skeletal dysplasia. If it's fine and both lower limb are affected, it will be proportionate short stature.
So like gigantism can be considered as skeletal dysplasia, so like Marfan's or Ehlers and loss. Is it?
Yeah. Yes.
That.
Yeah, that's also that is also come in the classification also. So if the short stature is also problem, the long stature also is problem.
So whatever is known cause like metabolic and endocrine, other than that, we can consider it as a
skeletal. Yeah.
Anything else we have to rule out, sir?
We need to rule out even the physiological or constitutional. If the parental history is there, it is also having with the short stature. Short stature, we need to find out whether it is family history is of short stature is there, the constitutional post stature. If the child is born with the IUGR, it will be also short. So we need to start from the parents' history, perinatal history, postnatal history. And we need to find out. Actually, the short stature is the most commonly has been evaluated by the pediatrician. When it comes for the orthopedic surgeon, it will come whether it is to be paired with the deformity of the limb or the spine or abnormality. If it is the short stature, when you see cervical spine is normal, we can follow up also.
So, when you have explained about rhizomelic, acromelic, and mesomelic, sir, because it is little confusing for about the rhizomelic. It is a skeletal dysplasia. Mesomelic can also be a type of.
No, all are skeletal dysplasia. If the upper limb, upper segment is short, it is called as rhizomelic dysplasia. Like rhizomelic dysplasia is commonest is like achondroplasia, where the humerus and femur is short. So whether in clinical examination, I said whether it is a rhizomelic, mesomelic, or acromelic. Sometimes it is a rhizomeso, rather mesoacro. Okay, so it is we need to identify which segment is short.
Just one or two questions about that mid-lung deformity, because that is also a type of, and this is usually given in that
that is a mesomelia. The mid-lung is a middle segment, so it is like a mesomelic type of display. It's a Larry-Willis dysplasia. It is mid-lung is also a dysplasia, and a SOX2 gene is involved. SOX gene is involved in the mid-lung deformity, but it is actually involving the radius and ulna. There are the multiple dysplasia. The mesomelic dysplasia also there are at least 15 to 20 types of mesomelic dysplasia. What I have shown the example in ankle, it is also mesomelic dysplasia.
So, I think because most of the question we have covered, you already have exhausted. Just the last one, sir, which I want to ask is about the, you have explained about the when spine is involved. So, in that one, sir, is there any example if you can give? Because
so the spine very common.
Spine.
Yes, sir.
Spine, whether it is common to have either the instability, deformity, or whether it's stenosis. In case of the achondroplasia, it is called very common to have either the cervical spine instability or lumbar spine stenosis. The patient may present with the instability or a stenosis. If there is an instability, it has to be stabilized. If it is stenosis, we have to require decompression. Or it will be present with the scoliosis. Very common to have a kyphoscoliosis, which will require about correction. So the spine, there are the three important aspects: instability, deformity, and particular stenosis.
Okay, great. Thank you very much, Hitesh. That was excellent. And I know it's a big, difficult area to cover, but you've certainly made it a lot easier for most people to understand it. Till next week, bye everybody, and hopefully things can. I think the things are getting busier and busier, so it's going to get more difficult to keep going. Okay, so good, great. Thanks a lot, Hitesh.
Okay, thanks.
Okay,
Thank you.
okay.
Good
Bye.
night. Good night.
Bye.
Bye.
Bye, everybody.
Thank you so much, sir.
Sure.